chest pain due to myocardial ischemia, wherein during ischemia class, yung coronary vessels natin or the one that is found, no, the artery, no, that is found within our heart is obstructed. So therefore, yung normal flow of oxygen is also disrupted, wherein the common cause is atheromatous obstruction within the coronary artery or the coronary vessel. So this is an example of a diseased artery. So as you can see, there is plaque formation, which causes the obstruction of blood flow, no? And then causing now angina pectoris or chest pain. So there are three forms of this angina pectoris. Number one is the classic or the effort angina that is due to the ischemia. This is also known as the stable angina, wherein usually this is triggered by physical activities such as exercise. And then even the food that we eat, no, can also trigger a classic or an effort angina. Emotions, food, then even physical activities such as exercises can trigger, no, classic or effort angina. Then, however, the good thing about this type of angina, it can be relieved by rest. Next is the variant. We also have the vasospastic or the Prinzmetal angina due to the spasm of the coronary vessel. So the problem with this type of angina, it occurs even at rest. So again, the variant angina occurs, no, even at rest. And then next would be the unstable angina that is caused by rupture, no, in the plaque. So again, if the plaque, no, if this atheromatous plaque ruptures, it causes now the unstable angina because it will completely obstruct, no, the flow of blood when this plaque ruptures, pag pumotok, no, yung plaque. So we call this type of angina as unstable. So what are the drugs used for the treatment of this condition, of this heart condition? So we have the following, no, the nitrates, the calcium channel blockers, and then the beta blockers. Specifically, their action is to promote vasodilation. Kasi nga, di ba, the coronary vessels are narrowed because of the presence of the atheromatous plaque. And then now the blood flow is obstructed. So in order to address the condition, what we can do is to promote vasodilation so as to normalize the blood flow. So what are the factors that can promote vasodilation? So increasing cyclic GMP, which is the action of the nitrates, decreasing the intracellular calcium, and then increasing the potassium efflux. So for the nitrates, the mechanism of action would include the release of free nitrite and then the production of nitric oxide. Causes now, no, the production of nitric oxide. The thing about nitric oxide, this is a potent activator of the guanylyl cyclase. So when this enzyme, guanylyl cyclase, is activated, it will increase the cGMP levels. And going back, one of the factor that promotes vasodilation is to increase the cGMP. So the release of the free nitrite causes the production of nitric oxide that will activate now the guanylyl cyclase to increase the cGMP levels and now causing smooth muscle relaxation. And the final endpoint is vasodilation. So we have the following examples of these nitrate products. We have the nitroglycerin that is also available in patches. Amyl nitrite, the isosorbide dinitrate that can be administered sublingually under the tongue, and then the isosorbide mononitrate. So for the toxicities of nitrates, usually the toxicities of nitrates are the extension of their effects. Number one, a common effect of nitrate would be throbbing headache. throbbing headache because aside from peripheral vasodilation, it would also cause the vasodilation of the cerebral arteries sa brain natin. So, ang nangyayari kasi when these arteries in our brain are dilated, it will cause an increase no, in the blood flow and increasing now the intracranial pressure. So, yung increase of blood flow sa brain natin and then increase intracranial pressure causes the headache. Kaya it's a direct extension of the effect of the nitrates kasi since the nitrates causes vasodilation, not only peripheral vasodilation but it would also cause vasodilation of the cerebral arteries resulting to increase in the blood flow or increase intracranial pressure in our brain. In fact, ang throbbing headache tinatawag din tong Monday sickness. So I'm not sure no, if you are familiar with this, but throbbing headache is also caused Monday sickness kasi nakita siya dun sa mga taong nagtatrabaho sa factory ng nitroglycerin. So example, no, halimbawa na nagtatrabaho sila dun sa gawaan ng nitroglycerin from Monday to Friday, they do not usually experience headache kasi nga since everyday silang na-expose sa nitroglycerin, nagiging resistant sila or they develop resistance against nitroglycerin. So they usually not or they become resistant no to the headache resulting from exposure to nitroglycerin. So since halimbawa ang trabaho lang nila from Monday to Friday, so weekend, Saturday, Sunday, uuwi sila, no work. Tapos pagbalik nila ng Monday, no, after the weekend, they are exposed again to the nitroglycerin. And then after nun, they already lost their resistance kasi nga nag-break sila during the weekend. So when they get back on Monday, they again exposed to nitroglycerin and then experience the headache. Kaya tinatawag siyang Monday sickness. Kasi naka-form sila ng resistance during the work period. Then, nagkaroon ng break because of the weekend. Tapos pagbalik ulit nila ng Monday, na-expose sila ulit and then naka-experience sila ng headache. Kaya tinatawag ang throbbing headache as Monday sickness no, because of that observation when for those individuals working in a company no, manufacturing nitroglycerin. And then aside from that, they usually experience toxicities, no, we also have orthostatic hypotension and then tachycardia. Tachycardia kasi nga the effect of nitrates is vasodilation. So kumbaga ito yung way of compensating nung heart natin no, to address yung effect ng vasodilation. That is to increase the heart rate. So this is the way of our body no, to address or to compensate the effect of the nitrate, which is vasodilation. And then another heart condition that we need to discuss would be the hypertension. So hypertension, this is defined no, as the blood pressure that is elevated at above 121/80 millimeter mercury. So there are two types of hypertension, the essential or the primary hypertension with no specific etiology or no specific cause, but somehow no, it is associated with genes, lifestyle, and even diet. Tapos ang non-essential or secondary hypertension is usually seen due to a specific disease such as adrenal stenosis and then in pheochromocytoma. So we have essential or the primary and then the non-essential or the secondary hypertension. So we have the following drugs that is used for the treatment of hypertension. We have diuretics, we have the sympathoplegic agents, the calcium channel blockers, the ACE inhibitors, and then the ARBs or the angiotensin II receptor blockers. So all of these antihypertensive agents would produce their main toxicity, which is hypotension or low blood pressure. So review lang tayo of the diuretics. Remember class no that our diuretic agents, they target the different sites within the nephron. So nandito yung specific site of action nila. Although, hindi ko na to masyadong i-discuss since you were able to discuss this in your pharmacology, but just take note no of the different sites of action of diuretics within the nephron. And then ang goal ng mga diuretics is to promote no to prevent the reabsorption of sodium and then water so as to reduce no the blood pressure. So by promoting the excretion or the elimination of sodium, remember where the sodium is, the water follows. So promoting their elimination would significantly reduce the blood pressure. So increasing no the urinary loss of sodium and water would reduce the blood pressure. So instead of the sodium and other ions being reabsorbed, they are eliminated via the urine. So we have the following diuretic agents classification. No? We have the carbonic anhydrase inhibitors, wherein it inhibits the reabsorption of bicarbonate ion. The loop that targets the sodium-potassium 2-chloride transporter. We also have the thiazide and then the potassium-sparing diuretic. But the most toxic and then the most potent diuretic would be the loop diuretic. So this is considered to be the most potent diuretic among the diuretic agents that we have here. And I think you are most familiar with furosemide. Then we have the carbonic anhydrase inhibitor. Although, mas ginagamit na kasi ang mga CAIs ngayon sa glaucoma. If you are familiar with brinzolamide. Yan kasi yung aking drug no, during my graduate school research. So, carbonic anhydrase inhibitor yun na ginagamit for glaucoma treatment, si brinzolamide. And then, we have the potassium sparing. So, itong action niya is to either inhibits the aldosterone, particularly the action of spironolactone and eplerenone. And then, the amiloride and triamterene would inhibit the sodium influx. So, let us discuss yung kanilang toxicities. So, first of all, we have the carbonic anhydrase inhibitors that causes the following. Acidosis, urinary stone, hypokalemia, and drowsiness. Para mas maintindihan natin yung effect ng acidosis, let me draw. Yan. So, meron tayong tinatawag class na acid-base balance no, sa body natin, wherein the levels of the bicarbonate ion tsaka nung hydrogen ion is maintained to, balik rin natin. Yan, hydrogen ion tsaka bicarbonate ion. That maintains the acid-base balance. Yan, acid-base balance. So, balikan natin yung action ng carbonic anhydrase inhibitor. It inhibits the reabsorption of bicarbonate. So, ibig sabihin, when the reabsorption of bicarbonate ion is inhibited, what will happen to bicarbonate? Instead of being reabsorbed, it will be eliminated. So, ang mangyayari ngayon, anong mangyayari ngayon class sa concentration ng bicarbonate ion going back to this acid-base balance? What will happen to the amount of bicarbonate ion in our body when the carbonic anhydrase inhibitors promote the excretion or inhibits rather the reabsorption of bicarbonate ion? What will happen to its concentration? Tataas ba or bababa? Decrease. Therefore, ano ang effect ngayon ng carbonic anhydrase inhibitor? Acidosis. Bakit po acidosis? Kasi nga, the bicarbonate ion, the reabsorption of bicarbonate ion is inhibited. So, bababa ang level ng bicarbonate ion, tataas ang hydrogen ion, therefore, acidosis. Can you follow? Please hit the thumbs up button if yes, or should I repeat it? Ako na, ayan. So, ayan, may mga nag-thumbs up naman. Again, babalikan natin, no? Ang sabi dito, it inhibits the absorption of bicarbonate ion. So, ibig sabihin, the bicarbonate will not be reabsorbed. And then going back to the acid-base balance, so if the bicarbonate ion will not be reabsorbed, definitely the concentration of the bicarbonate in the body will decrease. And ano yung magdodominate? Yung hydrogen ion causing acidosis. Then other toxicities of carbonic anhydrase inhibitor would include urinary stone such as phosphaturia, wherein phosphate ions are usually eliminated or excreted through the urine, phosphaturia, hypokalemia, and then drowsiness. How about loop diuretics? So loop diuretics are known to be ototoxic. In fact, dose related. So pag mataas yung dose, mas mataas yung tendency nila to be ototoxic. And then lalo na kung loop diuretics are given together with other drugs that are known to be ototoxic. So example, yung mga antibiotic agents natin such as aminoglycoside. So ang mga aminoglycoside antibiotics, they are known ototoxic agent. And when they are given together, they can increase the chances of ototoxicity. Ano pa yung isang condition? Kapag, example, binigay din sila sa mga patients na may existing renal condition. So, halimbawa, may renal impairment. So, it could also enhance yung possibility of ototoxicity for loop diuretics. And then next is metabolic alkalosis. So, babalikan ulit natin yung acid-base balance. So let me erase this one. So again, we have hydrogen ion, tapos bicarbonate ion. Yan. So ang effect kasi ng loop diuretic is there is increased delivery of hyponate of sodium ion. So ibig sabihin, class, the loop diuretics will prevent also the reabsorption of the sodium ion. So, yung sodium ion concentration is affected. Kaya lang, ang problema kasi sa loop diuretic, it will not only affect or it will not only prevent the reabsorption of sodium ions, but affected din yung potassium, tsaka yung hydrogen ion. So, hydrogen ion. So, not only sodium ion causing hyponatremia and potassium ion, even the hydrogen ion. So, since affected ang reabsorption ng sodium, potassium, and hydrogen ion, what will happen now to the concentration of the hydrogen ion? Bababa, tataas ng hydrogen. So ang loop hindi lang limited sa amount ng sodium ion yung effect niya, but it will also affect yung reabsorption ng potassium tsaka hydrogen ion. So what will happen now, class, to the hydrogen ion? If these two ions would have the same fate with that of the sodium ion, what will happen? Will it increase or decrease the hydrogen ion? Ulitin natin ha, ang loop diuretics will prevent the reabsorption of sodium ion along with potassium and hydrogen ion. So what will happen now to hydrogen ion? Bababa ba tataas? Tingnan nyo yung toxicity niya, metabolic alkalosis. So pag metabolic alkalosis, alin ang nagdo-dominate? Alkalosis. Bicarbonate, ibig sabihin, kaya nga siya alkalosis, ibig sabihin, greater yung amount ng bicarbonate ion. Bakit po naging ganon? Kasi nga, di ba, hindi na reabsorb ang sodium, potassium, tsaka hydrogen. So, syempre, ang magdo-dominate sa atin ay bicarbonate. Kaya alkalosis. Hindi lang sodium ion ang affected ng loop diuretic, even potassium and hydrogen ion. So, potassium and hydrogen ion will also not be reabsorbed. So, ibig sabihin, bababa din ang amount ng hydrogen ion and tataas ang bicarbonate ion. Kaya alkalosis. So, mas mataas yung level ng bicarbonate kumpara sa hydrogen ion. Can you follow? Please hit the thumbs up button if yes. Ayan. So, titingnan nyo lang, alkalosis. So, ibig sabihin, mas mataas ang bicarbonate. Then, aside from hyponatremia, hypokalemia, hypomagnesemia, hypocalcemia, take note ha, hyperuricemia. So, hypo, pero nag-iisa lang yung hyper, which is hyperuricemia. So, it can precipitate gout attacks, ang mga loop diuretics. So, we have to be very careful in giving loop diuretic to patients with gout kasi they can cause hyperuricemia or an increase in the uric acid. Then thiazide would exhibit the same toxicity with that of the loop diuretic rather, hypokalemia, hyponatremia, although mas malaki yung chances talaga pag loop. Tapos puro hyper. Ano yung mga hyper? Hyperuricemia, hyperglycemia. Kaya you have to be very careful when giving thiazides for patients who are diabetic kasi they can cause an increase in the blood sugar level causing hyperglycemia. Tapos hyperlipidemia, specifically yung mga LDL levels natin. So, thiazides can also increase the lipid levels such as yung mga LDL and yung mga cholesterol level. So, potassium-sparing diuretic on the other hand, kaya nga from the name itself, they will prevent the elimination of potassium. So, instead, they will only promote the elimination of sodium but not of the potassium ion. Kaya nga, instead of hypokalemia, it causes hyperkalemia. So, erase na lang ulit natin. And then, metabolic acidosis. Kasi, bakit class? Ang concentration kasi ng potassium, nakaparallel yan kay hydrogen ion. So, kung hindi mai-eliminate si potassium, hindi rin si hydrogen ion, kaya acidosis. So, yung concentration, yung secretion, reabsorption ng potassium, parallel siya with the hydrogen ion. Since the potassium-sparing diuretic spares the potassium ion causing hyperkalemia, same with the hydrogen ion concentration. Kaya metabolic acidosis. Kaya anong mapapansin nyo, class? Pag hypokalemia, ano ang laging meron? Metabolic what? Pag hypokalemia, metabolic alkalosis. Pero pag hyperkalemia, this is accompanied with metabolic acidosis. So, hypokalemia, metabolic alkalosis, hyperkalemia, metabolic acidosis. And then, acute renal failure. Then, for spironolactone, meron siyang anti-androgenic effects such as gynecomastia, impotence, and then triamterene causing nephrolithiasis. So, more on renal effect ang meron din yung ibang potassium-sparing diuretic. Specifically, when you give triamterene with indomethacin. So, meron siyang renal effect when the triamterene is given together with indomethacin, which is an anti-inflammatory agent. Then lastly, we have mannitol, so which is an example of an osmotic diuretic. So, ang ginagawa ng mannitol, it draws water into the lumen of the proximal convoluted tubule and then descending limb of the loop of Henle. So, not much of the ion, pero the mannitol causes the withdrawal of water into the lumen. So since it's not well absorbed within the nephron of the kidney, so ang gagawin na lang niya is to draw or to extract water from the kidney cells and then later on causing diuresis. Kaya nga ang initial effect ng mannitol would be extracellular volume expansion. Bakit extracellular volume expansion? Kasi nga it will draw or it will extract water from the cell. So, saan pupunta yung water? Outside the cell, extracellular. So, causing an increase in the extracellular volume. Hypernatremia due to dehydration. So, kasi nga, since ang effect ng mannitol is diuresis, kapag walang proper hydration, it can cause hypernatremia. Kasi nga, ang gagawin ng mannitol is to promote urination or diuresis. And then kapag hindi pa nag hydrate or hindi uminom ng maraming tubig, let's say when there is mannitol treatment, so it can cause dehydration and dehydration with hypernatremia, causing or resulting to hypernatremia. And then hyponatremia naman for patients with decreased renal function kasi kapag halimbawa binigay yung mannitol dun sa mga taong merong renal impairment, ang problema kasi the mannitol is not effectively excreted by those patients with impaired renal function. So instead of the mannitol being excreted, it is retained in the blood. So ang gagawin lang niya is to draw up water from the cell, but it will not be excreted for patients with renal impairment. So hence, instead of hypernatremia, hyponatremia naman. Kasi it will remain on the blood and continue to extract water from the cell. Depending on the route of administration, iba rin ang use ng mannitol. So kapag intravenous route, as a diuretic, pero pag orally administered as a laxative agent. And then we have the sympathoplegics, so alpha antagonists, di ba, the zosins for as an alpha-1 antagonist. We have the zosine, the non-selective antagonists, alpha-1 and alpha-2, the alpha-2 selective agonist, the clonidine and methyl-dopa. Methyl-dopa is rarely used except for pregnant women. So ang pinaka-indication niya is during pregnancy, hypertension during pregnancy. Tsaka beta blockers, lastly, we have the olols, like the selective, beta 1, and then the non-selective. Then toxicities, the orthostatic hypotension, reflex tachycardia, kasi nga biglang bababa yung blood pressure no, when these drugs are taken. So ang compensatory mechanism ng katawan natin is to increase the heart rate in order to increase the blood pressure. And then rebound hypertension. So we have, kung natatandaan nyo sila alpha antagonists, yung mga first dose effect, orthostatic hypotension. And then lastly, we have the ACE inhibitors and then the ARBs, the angiotensin 2 receptor blockers, sila prils, tsaka sila sartan. So initial toxicity, hypotension, just like any other antihypertensive agent. Teratogenic, specifically ACE inhibitors. So never give ACE inhibitors during pregnancy because they are known to be teratogenic. Hyperkalemia with ACE inhibitors, cough, especially with ACE inhibitors, and then angioedema. Ang ginagawa kasi ng ACE inhibitors, aside from inhibiting the conversion of angiotensin 1 to angiotensin 2, it will also prevent the breakdown of bradykinin. So it prevents the breakdown of this chemical known as bradykinin. This is letter K. So instead of bradykinin being broken down, bradykinin is preserved. So ang nangyari, it causes now cough. Yeah. Because the ACE inhibitors prevents the breakdown of bradykinin. So this is the one responsible for cough. So the good thing kapag halimbawa really the patients cannot tolerate the cough no from the ACE inhibitors, we have an alternative which is the ARBs, yung mga sartans na. So the usual alternative for ACE inhibitors, especially if they cannot tolerate the cough. And then we have the following respiratory drugs. So we are done finally with cardiovascular drugs. Ano nang ginagawa nyo, class? Nagugutom na ba? But we still have an hour left, no? Nakikinig pa, inaantok, mainit. Can I see some reactions para alam ko na nandito pa kayo sa Zoom? Ay, wala na, nakatulog na. Ang mga estudyante ko. Ayan, meron pa akong kasama, buti naman. So, discuss natin ng mabilis din yung mga respiratory drugs such as the antihistamine, antitussives, expectorants, nasal decongestants, and then bronchodilators. Tisin nyo na lang kasi free day naman tayo on Thursday. Ay, joke lang yan. Okay, so for antihistamine agents, so these antihistamines are usually indicated for which conditions? Di ba, we have allergy. Allergy which is caused by the binding of the histamine chemical to the H1 receptor within the smooth muscle and then the bronchi. So the histidine is converted by histamine via the histidine decarboxylase enzyme. And then again, once it binds to the H1 receptor, it causes the following: smooth muscle contraction and bronchoconstriction. Now, the effects of the histamine is antagonized by the antihistamine. So which is, or rather, antihistamines are examples of pharmacologic antagonists. Pharmacologic antagonist. Bakit natin sila tinawag na pharmacologic antagonist? Kasi antihistamines bind at the same receptor with that of the histamine, which is H1. So, if meron tayong pharmacologic antagonist, meron din tayong physiologic antagonist for the physiologic antagonist for histamine, which is epinephrine. So, bakit natin siya tinawag na physiologic antagonist? Kasi ang epinephrine binds at a different receptor. But it can oppose the action of the histamine. So, pharmacologic antagonist binds at the same receptor, while physiologic antagonist, it binds at a different receptor. So, please take note. But both of them can oppose the action of the histamine. So, remember, class, we have first and second generation antihistamine. So we all know no na ang mga first generation antihistamines are CNS depressant. They can induce sedation and then blurring of vision. Kaya ano yung mga dapat nating i-remind kapag halimbawa that the patients are taking first generation antihistamine, bawal mag-drive, bawal mag-operate ng machinery kasi they can cause sedation. In fact, each type of first generation antihistamine can vary on their degree of sedation. So yung merong marked sedation would be those highlighted in pink. So these are examples of first generation antihistamine that can induce marked sedation. So we have the diphenhydramine, dimenhydrinate, tsaka si hydroxyzine. Kaya nga ang diphenhydramine, si Benadryl class, 25 milligrams lang yung pwede mong bilhin without prescription. Pero pag 50 na, naka-RX na yan. Although yun na yung sinasabi nila na pwede mo naman inumin na 2 beses, tapos meron ka ng 50. Pero yun lang, kasi nga, ang diphenhydramine ay, it's one of the first generation antihistamine that can induce marked sedation. Kaya yung iba nagiging dependent dito, ginagawa nilang pampatay. Then, toxicity aside from sedation and blurred vision, this is what you have to remember about first generation. They can also exhibit anticholinergic effects. So anticholinergic, just like atropine. So they can also exhibit or produce such effect, anticholinergic effect. Ang mga first generation, which makes them different. No? By the way, itong mga alkylamines, ito yung nakikita natin kasama yung mga formulation natin, for example, together with phenylephrine and then paracetamol in combination with other agents. And then we also have yung mga second generation antihistamine natin na lacks, no? They lack the CNS depressant effect and then even the anticholinergic effect. So therefore, kung halimbawa ayaw nyong antoken, you can take instead second generation antihistamine. Kasi nga they lack, no, the sedative effect and then even the anticholinergic effect produced by the first generation. Although some of them can cause dizziness, nausea, and abdominal discomfort. So in place of the first generation, we have the following second generation antihistamine. Then we also have antitussive agents, no, for dry cough, di ba? For dry cough. So we have the following, the codeine, which is an opioid derivative, so of the same origin with that of the morphine. Kaya nga may mga opioid effects ang codeine. But the good thing about the rest of the examples here, like noscapine, levoprovoxapine, and dextromethorphan, unlike the codeine, no, so they lack the opioid effects. So later on, we will discuss ano ba yung mga usual effects ng mga opioid drugs. So we have codeine, dextromethorphan, levoprovoxapine, and noscapine for dry cough. Ang codeine, usual side effect nito, constipation. Tapos yun nga, may possibility siya of opioid toxicity when given at a higher dose. So just like the morphine. But this is an antitussive, a very common antitussive that is being used before. So our antidote is naloxone because it will target the opioid receptor. Bago ako magsimula, meron pa tayong, ayan, less than 1 minute.